Welcome to Module 3 of this webinar. In this module, I will talk about the novel agents in the management of chronic coronary syndromes, and I will focus specifically on ranolazine because this anti-anginal has very distinctive mechanisms. In the previous modules, I explained and gave you and hopefully convinced you that there is enough evidence from clinical trials which suggest that we need a new, more inclusive management paradigm for stable angina patients, moving away from treating just an obstruction in the coronary artery and moving away from the concept of first, second, and third line anti-anginal agents. What guidelines consider third line or second line anti-anginal agents may be first line for our individual patient who has a specific mechanism. And the guidelines of the ESC recognize that. They say beta blockers and calcium channel blockers are recommended, but there is no randomized controlled trial to date which has compared this strategy to an alternative strategy using other anti-anginas like the ones we have available now. And they also say the initial choice of your anti-anginal drug depends on the patient characteristics, comorbidities, drug interactions, other therapies that the patient is taking, the patient preference. And they also have changed their recommendations to the point that drugs which were considered to be third-line drugs, like nicorandil, ranolazine, ivabradine, or tremetazidine, now have a 2A recommendation or a 2B recommendation depending on the situation. And in my view, they may have a first-line, a 1A recommendation in the individual patient if the mechanism that we want to treat is the mechanism that these drugs specifically target. So now we have a good choice of medication in our armamentarium to treat chronic stable angina. So let's talk about ranolazine, which is the focus of the talk today. This is a piperazine derivative with a mechanism of action that differs from all the other anti-anginal agents in our arsenal. Ranolazine is not such a new drug. It was approved by the FDA in 2006 for the treatment of stable angina pectoris, and the efficacy of ranolazine has been studied in patients with stable angina and diabetes, microvascular angina, unstable angina, etc., etc. So we know a lot about this agent. We also know that myocardial ischemia alters the ATP flux, and this causes a functional decrease in the energy that is available to the proteins that regulate myocardial function. When this electrolyte balance appears, then there are elevated intracellular levels of sodium and calcium, and the increase in intracellular sodium concentration is mediated in part by the activation of a very important sodium channel, which is the inward sodium channel current. And we know a lot about this sodium current and how an abnormality of the sodium channel can cause an increase of calcium into the cell, and that will lead to electrical instability, mechanical dysfunction, and a problem with the oxygen supply and demand. The heart becomes stiff as a result of the increased calcium concentration because of a failure of the sodium channel during ischemia. So irrespective of the cause of myocardial ischemia, we know that once ischemia develops, there is a sodium-induced calcium overload, there is an impaired LV diastolic relaxation that increases the tension on the left ventricle, and that increases oxygen demand. In addition, when there is ischemia and when there is sodium-induced overload, the coronary microvessels dysfunction because they're working in a very hostile environment, and therefore the oxygen supply is reduced. Ranolazine selectively reduces ischemia-induced sodium and calcium overload and improves myocardial perfusion and left ventricular function. And very interestingly, ranolazine, contrary to all the other anti-anginal drugs that we have available at the moment, has hemodynamic independence. It does not reduce the heart rate, it does not reduce the blood pressure, and it does not have vasodilatory effect. So we can combine these drugs with all of the others. There is a large amount of data in the literature confirming the beneficial effects of ranolazine in the symptomatic management of angina pectoris. The Marisa, Carissa, Erica, and Teresa studies have all confirmed the usefulness of this anti-anginal agent, and the Roe study has also confirmed the safety, the long-term safety of the use of ranolazine in patients with stable angina pectoris. There are several studies which have actually shown that there is also a gender-related benefit of ranolazine in terms of angina. Women with angina get significantly higher benefit, anti-anginal benefit from the use of ranolazine compared with men. And ranolazine has also been shown to have an antiarrhythmic effect, and I will have no time to go into this, but both in human studies and in animal studies, ranolazine has been shown to have an anti-anginal effect, and here is a list of the trials which have actually demonstrated this antiarrhythmic effect for you to go through in your own time. The other important concept in relation to ranolazine in angina is that the anti-anginal efficacy of ranolazine has been documented to be higher in patients with diabetes compared to those without diabetes. So it is effective in the whole group of stable angina patients, but diabetic patients benefit the most from this agent. And it not only improves angina and ischemia, but also improves HbA1c concentrations in patients with diabetes. These cardiometabolic effects have been documented in a large study, the Merlin study, which showed the reduction in HbA1c levels in patients with diabetes and also in patients without diabetes, but without causing hypoglycemia. In the Merlin study, ranolazine significantly lowered HbA1c in patients with established coronary artery disease and diabetes mellitus. And this is an important concept in relation to the use of this agent. And here I'm showing you graphically this reduction in HbA1c during follow-up in these patients compared to placebo. And this happened both in patients with diabetes and in patients without diabetes, but without causing any hypoglycemia. In addition to the beneficial effect on the glucose metabolism, there was also a reduction of the risk of recurrent ischemia during follow-up in these patients in the Merlin study. And more recently, Eckel and colleagues have actually given further evidence that ranolazine lowers HbA1c and improves glucose metabolism. And you can see the data here against placebo, reduction in HbA1c in these patients. And Eckel and colleagues concluded, like other studies previously, that the mechanism responsible for the cardiometabolic effects of ranolazine is due to a reduction in both glucagon and glucose with ranolazine, and the effect appears to be due to a reduced glucagon secretion from the alpha cells, which results in reduced glucagon levels. ECHO, like other studies in ECHOs and other studies in previously, have actually endorsed the concept that ranolazine could be a good option for the management of patients with concurrent stable angina and type 2 diabetes. And given the neutral to negative glycemic effect of compared to other anti-anginal drugs, patients with this condition may be really ideal for the use of ranolazine. So, and this is the final case I wanted to show you in relation to the use of anti-anginal agents, particularly ranolazine in this case. This is a 72-year-old man, Caucasian ethnicity, with effort-induced angina pectoris, daily episodes on walking upslope or on the flat, particularly on cold days, relieved by GTN. GTN unfortunately causes headache and hypotension, and this patient is not happy to use it. He has frequent palpitations. He has type 2 diabetes, which was diagnosed 8 years ago. Not a very good management of HbA1c with current anti-diabetic agents. He's overweight, slight reduction in glomerular filtration rate, normal liver function, slightly increased CRP, history of obstructive pulmonary disease, and he's an ex-smoker, heavy smoker. He had a silent inferior acute MI, as we occasionally see in patients with diabetes, and this happened a few years ago. He has dyslipidemia, and his blood pressure is low, with episodes of postural hypotension with a low heart rate at baseline. He underwent stress echocardiogram, which showed transient ischemia in the inferolateral wall at a relatively low heart rate. In the Holter, ventricular, isolated ventricular arrhythmia and supraventricular extrasystoles appear with 2 episodes of SVT. The cardiac MRI perfusion scan, as we are seeing more and more often now that we are doing this test routinely, there was circumferential LV hypoperfusion in addition to documentation of the scar of the previous MI. And the angiogram showed a blocked right coronary artery with 70% stenosis of the circumflex coronary artery. So for the management of these patients, we had to take into consideration what the guidance tells us in terms of improving clinical outcomes. And for this, very aggressive secondary prevention of coronary artery disease with all the measures we know, aggressive management of his diabetes with the use of the newer drugs and the newer anti-diabetic drugs, and of course the management of the symptoms of angina pectoris. All 3 elements which are indicated by the guidelines we have to take into account. So aggressive management of his risk factors, of course, diet, exercise, no smoking, talking to the patient a lot, making sure that he will comply with the changes in the medication. So he was given aspirin, clopidogrel, which is a 2A recommendation, ramipril, atorvastatin to bring his LDL cholesterol to the recommended levels. Metformin, we couldn't go more up to the dose we would have wanted because of some gastric effects, and he was started with empagliflozin 10 milligrams once daily. Would make a difference though to his symptoms, because he couldn't take the bisoprolol, we couldn't use calcium channel blockers because of the low blood pressure and the low heart rate. And in addition, he had pretty bad side effects in response to vasodilators. So we had to really compromise with very low dose of bisoprolol. So we had to add ranolazine, which we were very happy to do so because, as I said to you previously, the profile of this patient is ideal for the use of ranolazine with his diabetes, his obstructive coronary artery disease, his lack of his slow heart rate and his low blood pressure. So an ideal candidate for the use of ranolazine. And actually, after 3 months follow-up, his effort-induced angina improved significantly with only just occasional episodes. So basically, we moved down here. We moved to what is a 2A indication or 2B indication in the guidelines. For us was a 1A indication in this patient, the use of ranolazine. That was the ideal way of dealing with all the sort of background characteristics of this patient, his obstructive disease, his diabetes, his intolerance to the traditional conventional anti-anginal agents. So we comply basically with what the guidelines tell us in relation to the medication that should be given to somebody with slow heart rate, somebody with low blood pressure. So this agent, ranolazine, became option number 1 for this patient for the reasons that I have given to you previously. So based on the particularities of ranolazine, I think that this drug is useful in these patients that I listed here. People with chronic coronary syndrome, particularly those with low blood pressure and slow heart rates. Patients with angina despite successful inverted commas PCI. Patients with diabetes and obstructive coronary artery disease. Patients with coronary artery disease and LV dysfunction, because this drug does not affect hemodynamically these individuals. Patients who have AF because of the good effect of this agent in those patients. Very importantly, microvascular angina and in the elderly patients with chronic ischemia and multiple risk factors and contraindication to other anti-anginal agents. So in conclusion, I'm talking specifically about ranolazine. Ranolazine has contributed significantly to the armamentarium that we have available for the treatment of chronic coronary syndromes. Its lack of impact on the blood pressure and the heart rate makes it suitable for use in different clinical scenarios. As I said to you in Module 2, in recent years, many randomized, placebo-controlled clinical trials and meta-analyses have confirmed the benefits of this agent in chronic coronary syndromes. Its effects on the sodium channel is very promising at different levels, as ranolazine can reduce the incidence of AF and VT, has anti-arrhythmic properties, and also improves the metabolic profile of these individuals. Ranolazine has an acceptable safety profile as attested by the recommendations of the European Society of Cardiology guidelines published in 2019. And with this, I conclude this educational activity. I hope that I managed to convey the message that we really need to look at the characteristics of the patient, identify the prevailing mechanism of angina, think about the comorbidities in our individual patient before selecting the medication. Just don't rush to angioplasty because there is an obstruction in the coronary arteries. Consider all the possible mechanisms that can lead to angina pectoris and try to improve symptoms and outcomes with pharmacological therapy first before sending the patient for revascularization. And of course, revascularization has clear indications, very clear indications that benefit patients. So we are not sort of proposing something which antagonizes intervention, but just let's give us time before proceeding to revascularization. Let's give optimal medical therapy a chance. Thank you very much.